Om Swastiastu. We are from SGD B2 year 2020 and we would like to present our student project entitled Polyarteritis Nodosa. These are our group members.
My name is Tjokorda with the last three-digit number of 165. And today I will present you the introduction of polyarteritis nodosa, or what we actually call PAN. It is a form of systemic vasculitis that is typically rare. And even though it affects the medium-sized blood vessels, in some cases, in some studies, it also actually found and occurs in small muscular arteries. And it has several characterizations, such as necrotizing inflammation that occurs inside blood vessels within a medium-sized. Not just that, PAN is also characterized as an intimal proliferation that is causing occlusion stenosis. PAN is actually varies on its clinical manifestation. Thus, it is recommended to make a correct identification that will allow the diagnosis to be confirmed. And just like other vasculitides, PAN affects more than one system, and it also has a protean manifestation. But still, PAN commonly affects skin, peripheral nerves, joints, kidney, and also the gut. The treatment approach itself depends upon some variables. And because of this, it is also important to do some assessment before beginning the therapy of PAN. Those variables are such as severity of the disease, the presence of an isolated cutaneous PAN, and the presence or also the absence of viral hepatitis. So that's all from my presentation. The presentation will be continued by my friend. Thank you.
Greetings everyone. My name is Adiva Buana Putra Pratama, and I'm here to tell you about the problem formulation of our student project. The first one is, what is polyarteritis nodosa? The second one, how is the epidemiology of polyarteritis nodosa? The third one, what is the etiology and risk factors of polyarteritis nodosa? The fourth one, what are the clinical symptoms of polyarteritis nodosa? The fifth one, how is the pathophysiology of polyarteritis nodosa? The sixth one, how to diagnose a patient with polyarteritis nodosa? The seventh one, what are some examples of the management for a polyarteritis nodosa patient? And the last one, how is the prognosis of polyarteritis nodosa? Next. And these are the objectives of our student project. The first one is knowing the general description of polyarteritis nodosa. The second one, knowing the epidemiology of polyarteritis nodosa. The next one is knowing the etiology and risk factors of polyarteritis nodosa. Knowing the clinical symptoms of polyarteritis nodosa. Knowing the pathophysiology of polyarteritis nodosa. Knowing the diagnosis of polyarteritis nodosa. The next one is knowing the medication of polyarteritis nodosa. And the last one is knowing the prognosis of polyarteritis nodosa. Next. This is the benefits of our student project. The first one is able to know the general description of polyarteritis nodosa. The next one is able to know the epidemiology of polyarteritis nodosa. The third one is able to know the etiology and risk factors of polyarteritis nodosa. The first one is able to know the clinical symptoms of polyarteritis nodosa. The next one is able to know the pathophysiology of polyarteritis nodosa. Able to know the diagnosis of polyarteritis nodosa. Able to know the medication of polyarteritis nodosa. And the last one is able to know the prognosis of polyarteritis nodosa. Okay, that's all from me. The next presentation will be continued by my friends. Thank you so much.
Hello everyone, my name is Dewa Ayu Bintang Permatasari with the student number of 2002511211. So today, I would like to explain about the general description of the polyarteritis nodosa. Polyarteritis nodosa, as well known as PAN, is a systemic disease that has necrotizing vasculitis as its pathophysiology characteristic, and affecting predominantly on medium-sized arteries. Any type of vessels, including arteries, arterioles, veins, or capillaries, could be affected by this disease. Patients with polyarteritis nodosa commonly perform systemic symptoms, such as weight loss and fever. By the time of the diagnosis, the kidneys, skin, joints, muscle, nerves, and also the gastrointestinal systems are frequently affected, typically in some combination and occasionally all at once. PAN is becoming less in prevalence as a result of hepatitis B virus infection prevention. Nevertheless, this immune disease remains a potentially fatal diagnosis, with a mortality rate of 40% at 5 years for severe PAN.
My name is Yukta Iswari, with the last 3-digit student number is 118. Today I would like to explain about the epidemiology of Polyarteritis Nodosa, or PAN. PAN cases vary around the world. PAN reports are considered rare, with 1 case per million people each year. Cases found in children are also infrequent. Study in France shows that the prevalence of PAN is 30 per 1 million adults. Another study in the United States and Europe reports the number of PAN incidents reaching 2 to 9 per million. In Asian countries, Japan has 0.75 per million incidents. Alleviation of incidents happened in Poland between 2008 to 2013, which decreased from 3.3 per million to 1.9 per million due to lower number of hepatitis B cases. After the HBV vaccination program, PAN is less than 5% in developed countries. Men are more likely to experience PAN than women, and people with PAN commonly around middle age to older adults. It is mentioned that PAN is usually idiopathic. That's all from me. Thank you.
Hello everyone, my name is Putu with the last 3-digit number 103, and now I'm going to explain about the etiology of Polyarteritis Nodosa. Polyarteritis Nodosa has primary and secondary etiologies. As for the primary manifestation, the etiology is still idiopathic. It is still unknown and unclear, but it is suspected that lymphocytes B and T has a role in the inflammation of the vascular wall. It is also suspected that the innate immune system also plays a role in the manifestation of PAN. As for the secondary manifestations, it is associated with infections of hepatitis B virus, hepatitis C virus, human immunodeficiency virus, parvovirus B19, cytomegalovirus, Epstein-Barr virus, Streptococcus bacteria, Gracela bacteria, Toxoplasma parasite, Pseudomonas bacteria, and Trichinella parasite. It can also be triggered by drug, with the most reported case being usage of minocycline, an antibiotic drug. There are also allelic mutations of the CECR1 genes, which may cause adenosine deaminase 2, which can cause deficiency, and the result is similar to polyarteritis nodosa, although since the clinical manifestation is more than just vasculitis, this case of mutation is argued to be separated as another clinical entity from PAN.
Hello everyone, my name is Yosephina Taji with last 3-digit student ID number 087, and I will explain about the clinical manifestations of the polyarteritis nodosa. Clinical manifestation of patients with PAN may present systemic signs, and patients may have non-specific complaints such as generalized fatigue, weight loss, fevers, and arthralgias and skin lesions. The skin lesions that may appear on patients with PAN is erythematous nodules similar to erythema nodosum. As in other forms of vasculitis, palpable purpura may appear. And PAN can affect almost any part of the body. It has a predisposition to organs such as skin, gastrointestinal tract, kidneys, and nerves. In the nerve system, peripheral neuropathies are very common, about 50 to 70%, and central nervous system or CNS lesions may occur 2 to 3 years after the onset of PAN. And the central nervous system lesions may lead to cognitive dysfunction, decreased alertness, seizures, and neurologic deficits. In the gastrointestinal system, patients with PAN may report abdominal pain early in the disease process. The pain may be continuous or may be intermittent, but often occurs after meals, and the symptom has been described as intestinal angina. Patients with PAN also reported that they have experienced nausea, vomiting, melena, or diarrhea. Patients with PAN and renal involvement most often present renal artery vasculitis that may lead to protein in urine, impaired kidney function, and hypertension. Small percentage of small percentage of patients with this clinical involvement go on to require dialysis. The disease may also cause clinical involvement of the heart, but does not usually cause symptoms. And some patients develop myocardial infarctions or congestive heart failure.
Hello, my name is Komang Setiari Jaya with my last three-digit number 037. I would like to continue the presentation regarding the pathophysiology. The clear cause regarding the exact mechanism on how and what immune complexes cause vessel inflammation on polyarteritis nodosa is still yet known. What is known about this disease is that it is related to hepatitis B infections. The hypothesis result in two observations. First, polyarteritis nodosa patients have similar clinical manifestations either with or without hepatitis B. Second, with the increase of hepatitis B eradication actions, polyarteritis nodosa cases have decreased significantly. It is also known that polyarteritis nodosa is a systemic necrotizing vasculitis that affects medium-sized and sometimes small-sized arterial vessels. It is not related with the common vasculitis cause, which is anti-neutrophil phytoplasmic antibodies.
Greetings, I'm Dhiyo and my student identification number is 200251133. Vessels affected by polyarteritis nodosa get thicker as it undergoes inflammation through intimal proliferation. In turn, the vessel becomes narrowed and blood flow gets increasingly restricted, predisposing the vessels to thrombosis. Besides narrowing the lumen, polyarteritis nodosa also weakens the vessel, leading the development of aneurysm. These changes manifest in infarction and ischemia, which surface as the clinical manifestation of polyarteritis nodosa. The kidney is most commonly affected, although polyarteritis nodosa has also shown to affect multiple other systems, such as the skin, the musculoskeletal system, gastrointestinal system, neurologic system, and cardiac system. A research by Somnes et al. Done in 2019 looks for the characteristics of polyarteritis nodosa patients. Laboratory examination shows that patients with polyarteritis nodosa show erythrocyte sedimentation rate, leukocyte count, and CRP levels at tendencies to be at median 58 mm per hour, 10,400 per millimeter cubic, and 5.22 milligram per deciliter respectively. From 130 AMCHA tested patients, none turned out to be positive. Furthermore, computerized scope tomography angiography on 92 patients revealed 69 patients with renal artery microaneurysms, 17 patients with hepatic artery microaneurysms, 3 patients each with aneurysm at splenic artery and at branches of the superior mesenteric artery, 3 patients with occlusion at superior mesenteric artery, 2 patients with aneurysm at celiac trunk, 2 with renal subscapular hematoma, and 1 patient with splenic infarction. In addition, biopsy samples indicated necrotizing vasculitis to be present in medium-sized vessel across all tested patients. That's all I can state. Thank you very much.
Hello, my name is Karina with student number 2002511003, and I will be explaining about the diagnosis of polyarteritis nodosa. Routine laboratory tests may provide important clues to polyarteritis nodosa, but there is no single blood test that is diagnostic of this disease. If there is skin or muscle nerve involvement, a skin or muscle or nerve biopsy can be extremely helpful in coming to a definite diagnosis of polyarteritis nodosa. The diagnosis is confirmed by a biopsy showing pathologic changes in medium-sized arteries. The biopsy site may vary. Most biopsies are taken from skin, symptomatic nerve, or muscle. An angiogram of the abdominal blood vessels may also be very helpful in diagnosing polyarteritis nodosa. In order to be classified as a polyarteritis nodosa patient, a patient should have at least 3 of the 10 following American College of Rheumatology criteria. 1. Weight loss of more than 4 kilograms since beginning of illness. 2. Libido reticularis. 3. Testicular pain or tenderness. 4. Myalgias, weakness or leg tenderness. 5. Mononeuropathy or polyneuropathy. 6. Development of hypertension. 7. Elevated BUN or creatinine unrelated to the dehydration or obstruction. 8. Presence of hepatitis B surface antigen or antibody in serum. 9. Arteriogram demonstrating aneurysm or occlusions of the visceral arteries. 10. Biopsy of small or medium-sized artery containing granulocytes.
Hello everyone, my name is Khasandra Damara. With my last 3 name digit is 152, and I'll be explaining the prognosis of polyarteritis nodosa, or as we know, PAN. Untreated PAN has a poor prognosis unless with treatment. The major causes of death include renal failure and mesenteric, cardiac, or cerebral infarction. Relapses tend to occur within 5 years. PAN is associated with slow recovery, and if it includes the involvement of central nervous system, it will progress into poor prognosis for sure. Without treatment, approximately 10 until 20% of patients die within 5 years, with 50% dying within the first 3 months. With corticosteroid treatment, however, the 5-year survival rate surges up into 50 until 60%. The prognosis is worse if patients fulfill the 5-factor score, or as we know, FFS criteria shown in the slide. Age factor also contributes to poor prognosis, meaning that individuals aged 65 years and up are more prone to polyarteritis nodosa and prone to poor prognosis.
Hello, my name is Gusti Frangipani Vedanti. With the 3 last digit of my student identification number is 064. Today I'd like to tell you about the summary of this student project. For the conclusion, polyarteritis nodosa is a systemic vasculitis and it is occur in any type of vessels. It is such a necrotizing inflammation, and the clinical manifestation are numerous and almost affect any part of the body, commonly kidney, skins, joints, muscles, gastrointestinal tract, and other more. There are general signs of systemic inflammation, neurological symptoms, and also cutaneous indications. The goal of treatment is remission. We could use pharmacological and non-pharmacological treatment. For the pharmacological treatment, we could administer corticosteroid, prednisone, and methotrexate, and we could use antiviral drugs if it associated with hepatitis B or hepatitis J virus. For the non-pharmacological treatment, the patient with polyarteritis nodosa is needed to have a regular and long-term follow-up to monitor the disease and drug safety. For the prognosis, polyarteritis nodosa has a poor prognosis with a slow recovery. For the feedback of the student project, although polyarteritis nodosa has decreased in prevalence due to HBV vaccination program, but this disease remains a potentially fatal diagnosis and decrease in quality of life. So further research on prevention and treatment, especially in local regions, is needed to help reduce prevalence rates. And that brings us to the end of the student project presentation. I would like to apologize if there are any mistakes, and I would like to thank you for your time and for your attention.